My name is Jenna Lane. I'll be talking about extracorporeal membrane oxygenation. Ecmo was not something that we have discussed much in medical school, so I'll be talking about the basics, and I'll include some case samples, examples, and talk about the history of Ecmo. I will not be discussing the complex mechanics of Ecmo or the nuances of troubleshooting, so this will be a pretty basic discussion of Ecmo, but I hope this presentation is relevant to everyone. It was a really interesting topic to read about and learn about, so I hope you enjoy the presentation. I put my references at the beginning just because I wanted y'all to know that I got most of my information from Dr. Robert Bartlett, who is kind of the founder of Ecmo. He's a professor and surgeon at University of Michigan. I also use Miller's Anesthesia and an article from St. Luke's. So what is Ecmo? In the words of Dr. Bartlett, Ecmo is support of heart or lung function with mechanical devices, which is temporary, can be partial or total, avoids iatrogenic injury, so you stop hurting the lung with the positive PEEP ventilator. You decrease metabolism by not using the heart, things like that, and also you sustain life while bridging to decision, recovery, or replacement, as in organ transplant. So in many cases, Ecmo is a last-ditch effort. So just like this goose, he's making use of what he has. So there are classically two main types of Ecmo. The one on the left side of the screen is venoatrial. So blood is taken from venous circulation and returned to the aorta or any place in the arterial circulation. And the one on the right is veno-venous. Both provide respiratory support, but obviously only VA provides arterial support. So essentially, Ecmo is like bypass. So the patient's blood is rerouted outside of the body, oxygenated, and returned to the body, either in the venous or arterial system. So bypass, the whole goal is to divert the blood away from the heart and lungs, so that you can provide a motionless, bloodless field so the surgeons can operate. But this is very temporary. You can't keep a patient on bypass for days. And so that's kind of what Dr. Bartlett and his colleagues set out to do is, as many NICU patients just need a few days to recover from their respiratory distress, whatever may be causing them the respiratory distress. Often they just need some time to recover. So they wanted to continue bypass for a few days. However, bypass can be lethal if it's done for too long. In fact, Dr. Bartlett said that at least in the early 70s, bypass was lethal after about 2 hours. And apparently this had to do something with like bubbling the oxygen through the blood. And so Dr. Bartlett set out to discover a way to do BiPAP for longer. And the goal was a few days. So around this time, silicone had been discovered, which was used as the membrane for oxygen and carbon dioxide transport. And so that's what really enabled Dr. Bartlett to do Ecmo. So this is the first patient that they used Ecmo on. This was in 1971. Dr. Bartlett and his colleagues had experimented on dogs and sheep using that silicone membrane, and they were able to do Ecmo successfully for a few days. So apparently they didn't have the restrictions in experimental medicine as we do today. So when a patient arrived who was in a motorcycle accident and had a ruptured thoracic aorta, wound up with ARDS, as with many patients with ARDS, he just needed time. He had his aorta repaired, obviously, but he needed time for his lungs to recover. So they did a veno-venous BiPAP, and he was on Ecmo for a day and a half and survived. 3 years later, in 1974, this is baby Esperanza, which means hope in Spanish. Baby Esperanza had persistent fetal circulation, so essentially she was dying. And so Dr. Bartlett went down to grab his machine from the laboratory and used a VA bypass. And so he used that for a few days. She was able to recover and is still living, and that's a picture, a photo of Dr. Bartlett and the patient as an adult. So really exciting. This is from the ELSO Registry, the Extracorporeal Life Support Organization. They've been around since 1989, and they gather data on information on the use, complications, and outcomes from all patients supported with Ecmo from 170 member centers. So they have data on more than 45,000 patients worldwide who have been reported to the registry, and this includes 27,000 newborn, 9,000 children, and 2,500 adults. And so what this slide is showing is, it's kind of hard to see, but I believe this starts kind of in the early 90s and goes to present time. And if you see that spike there, that is from 2011. And so that was during the H1N1 outbreak. And so they had a huge surge of Ecmo used on adults with ARDS. And so apparently in this study, they had patients who were deemed likely to die were put on Ecmo, and they had a 71% survival rate, which is, I mean, it sounds pretty good to me. And this is another patient from St. Luke's. I just thought this was an interesting and exciting story, so I included it. So this is Ted Hodges. He was a college student at Notre Dame, came home for summer vacation, had an upper respiratory illness, but rapidly began to deteriorate and had a high fever to 104, was diagnosed with viral myocarditis, and was airlifted to St. Luke's in Kansas City. Shortly after he arrived, he suffered a cardiac arrest. They performed CPR for more than 40 minutes, during which time a surgeon placed the catheters for Ecmo and then induced hypothermia for 24 hours. And then after a day, they warmed him back up, and he was alert and able to follow commands and alive. A week later, he received an LVAD, and a few months later, he received a heart transplant. He went back to Notre Dame and won the 2011 fencing championship. So it's pretty exciting. So Ecmo is a really exciting innovation in medicine, and I really hope to be involved in it in the future in residency. And thanks for listening.